We're doing anti-NMDA receptor encephalitis. So before we get into the disease, I just want to talk about the NMDA receptor itself. Malfunction in this receptor is actually what the disease is, so it's important that we go over the receptor. There are two subunits on the receptor, NR1, which binds glycine, NR2, which binds glutamate, and then there's this Mg stuck in the channel pore that requires a depolarization to get kicked out. Now, all three of those things are required to activate this channel. Activation of this channel is non-selective to cations, so calcium and sodium, which are concentrated outside the cell, can flow in. Potassium can flow out. And I just have a video here to further show this. So you got NR1 on the left, NR2 on the right, glycine's binding to NR1, glutamate's binding to NR2, right? And then you're gonna see this AMPA over here interact with the membrane, cause a depolarization which kicks off the Mg. Sodium and calcium outside the cell are allowed to flow in, potassium can flow out. Calcium's the most important ion that's involved here because it activates intracellular signaling cascades, which can be seen right down here. There's enzymes for signaling and kinases and phosphatases that control intracellular activity, and this is the basis of learning and memory, so it's very important. Hyperactivity in this channel is thought to produce seizures and epilepsy, which makes sense, right? And hypoactivity is thought to induce schizophrenic symptoms to the disease. So in 2005, people were presenting to the hospital with psychotic behaviors, and we weren't sure what was going on with them until eventually we found NMDA antibodies in their cerebral spinal fluid, right? So if we're forming antibodies to our own receptors, then essentially this is an autoimmune disease, right? So antibodies are forming against NR1 and NR2, right? These two subunits. It is thought though that NR1 is the subunit that's more primarily attacked. We're not sure if there's significance to that or not. So this attacking of NR1 and NR2, it binds antagonistically, right, and inhibits activity. That is why it's mixed diagnosed for schizophrenia, because a lot of the symptoms that are presented are similar. Oftentimes they believe it's schizophrenia and then it actually is not. So these antibodies don't come out of nowhere. They are either induced by paraneoplastic teratomas or viral infections. If you're unfamiliar with paraneoplastic syndromes, basically cancer causes other things in the body other than what you normally think of as a tumor or a cancer. So specifically with anti-NMDA receptor encephalitis, you have ovarian tumors. We're unsure why those are the tumors that happen the most with this disease, but for some reason they do. There's an immune response to this tumor. So the ovarian tumor has antigens on it. These antigens produce an immune response, but these antigens also mimic the NMDA receptor, which causes an autoimmune response, right? So then we have viral infections that can mimic this as well. So you're having antigen mimicry of this receptor, which is causing inhibition of the receptor activity. As you can see here, the functional changes due to the lack of activity in this receptor are very severe,
I will be focusing on how the N-methyl D-aspartate receptor, also known as NMDAR, plays a key role in anti-NMDA receptor encephalitis. I will also be focusing on a brief overview of the mechanisms involved in this disease. Immunoglobulin G, IgG, is the most prevalent antibody found in our bodies. IgG is part of our immune system to offer protection against bacterial and viral infections. Anti-NMDA receptor encephalitis is described as having IgG1 and IgG3, which are two subtypes of the IgG antibody class. The Fab fragments of these antibodies, which is the Y-specific portion of the antibodies shown here, binds to antigens, and this binds to the epitopes on the NR1 subunits of the NMDA receptor in cerebral spinal fluid. Essentially, our body is recognizing NMDA receptors as foreign antigens, which needs to be taken care of because they are seen as a threat to our homeostasis. This reduction in surface and synaptic NMDA receptor density Likely is the underlying factor regarding why learning, memory, and other deficits are observed with individuals diagnosed with anti-NMDA receptor encephalitis. After diligent research regarding the mechanism, it is now known that this reduction in NMDA receptors can be reversed. After removing antibodies in the CSF, postsynaptic density surrounding excitatory synapses was observed to increase. Because of the selective antibody-mediated capping and internalization of surface NMDA receptors, they are not being completely destroyed, they're just being hidden. The antibodies involved selectively only decrease NMDA receptor current. There have been no observed effects on the AMPA or GABA currents. Researchers have been able to separate the constant FC region and the specific Fab region of antibodies collected from several patients afflicted with anti-NMDA receptor encephalitis. The Fab region, which binds to the suspected antigen, or in this case, the patient's NR1 subunit on their NMDA receptors, was utilized and applied to control neurons. The Fab fragments were found to bind to the NR1 clusters on the NMDA receptors found on control neurons, thus eliciting the same effects as seen with the patients with anti-NMDA receptor encephalitis. ELISA, or enzyme-linked immunosorbent assay, was used to determine that antibodies from the patient reduced the NR1 in a teeter-dependent fashion, which basically just means that glutamatergic synaptic function is greatly decreased without a change in the number of synapses present.
In the early stages of anti-NMDA receptor encephalitis, many patients present flu-like symptoms, headache, low-grade fever, and fatigue. The first signs of illness are followed by a psychotic stage where patients exhibit paranoia, visual or audio hallucinations, anxiety, confusion, memory deficits, and disorientation. At this point, most patients are hospitalized. As the disease progresses, patients show decreased consciousness, movement disorders, seizures, decreased breathing rate, and heart dysrhythmias. If the disease progresses this far, patients may fall into a coma and the disease may be fatal. Diagnostics for this disease aren't straightforward and test results are not consistent with all patients. The EEG is one method used to diagnose encephalitis. It is abnormal in 89% of patients. Patients with encephalitis show a highly specific EEG abnormality called extreme delta brushes. However, according to Dr. Tiddle, this extreme delta brush pattern is not seen on the regular psych ward, but only in the ICU when the patient is severely ill. MRI is another method used, but is abnormal in only 1/3 of patients. Testing of the cerebrospinal fluid is necessary in diagnosing. Scientists are using a cell-based serum to evaluate CSF, but relying solely on a cell-based serum, doctors might miss 1 in 4 cases of anti-NMDA receptor encephalitis and might misdiagnose the disease in 0.4 to 3% of healthy individuals. Since the disease is so rare and the symptoms are comorbid with many psychotic disorders, the disease is often misdiagnosed as schizophrenia or psychosis. Paraneoplastic syndromes occur in patients with a neoplasm, or a new and abnormal growth of tissue in some part of the body, and it is an altered autoimmune response to this neoplasm. One disease that can result from paraneoplastic syndrome is encephalitis. In some cases, the body produces NMDA receptor antibodies designed to bind to NMDA receptors on the neoplasm. While this can be effective in slowing neoplasm growth or rarely completely destroying it, the antibodies can begin to attack normal brain cells, resulting in anti-NMDA receptor encephalitis. Because of this, patients who have tumors, malignant or benign, are more susceptible to the disease, specifically women with ovarian teratoma. However, the disease is also seen in patients without any abnormal growths. The median age of diagnosis is 19 years old, and the ratio of women to men diagnosed is 8.5 to 1.5. Mainly found in young women with ovarian teratoma, diagnosis has been reported also for older patients, women without teratoma, men, and children.
I'm going to be focusing on treatment options for anti-NMDA receptor encephalitis. So treatment options are limited, but the ones that are used seem to be effective. About half of cases are tumor-related, so following diagnosis, a tumor should be screened for and removed if present. The most commonly found tumor is an ovarian teratoma, which is shown in this video. Not all teratomas grow to be this large, but without proper diagnosis and treatment, this could be the outcome. So with or without a tumor, patients will receive IV steroids and immunoglobulins. For example, Immunoglobulins primarily reduce the level of synthesis of endogenous antibodies that are attacking your system and arrest further neuronal damage. Approximately 50% of patients who receive these first-line treatments will see improvement within 4 weeks. As a second option, plasma exchange can be used in conjunction with or after failure of first-line treatments. Plasma exchange involves the extraction of the patient's blood, removal of the plasma that contains the antibodies that are attacking your system, and replacement with new plasma that will then be transferred back into the patient. This is considered a second-line treatment because of the 20% complication rate due to the difficulty in performing it in children and uncooperative patients. There is also an increased susceptibility to infections due to the weakening of the immune system. So as of right now, 40% of patients will fully recover, 28% will have mild stable deficits, 18% will have severe deficits, and 7% will result in death. So in the future, with better treatments and quicker diagnosis, we could increase the percentage of full recovery.